Hello, everybody, and welcome to today's meeting, Hedis Measures for Collaborative Care. My name is Jocelyn Teeter McBride. I'm the Senior Manager at Consulting Services with CCSI. We are a MCTAC partner. This is brought to you in collaboration with MCTAC and CCSI. I'm joined by our two presenters today, Lynette Thielen and Amy Jackson, who will introduce themselves shortly. Just a few logistics about today's meeting. As we've done in the past, this webinar is going to be recorded. It will be posted with the slides on our new website, which we have a slide about at the very end. It's been refreshed and reformatted a little bit for you, much more user-friendly. We'll be taking questions and comments. If you'd like to speak up, feel free to raise your hand. I can try to identify you and chat to you if you have some questions. Feel free just to chat in questions for the end as well, or any comments that you have throughout. We ask that you put yourself on mute just in case you get unmuted. Just double check that you have that little icon swiped through. I will go through. Everyone should be muted upon entry. Again, please feel free to chat in our chat box functionality throughout. And with that, I want to thank you all for joining us again. And yes, the recording will be shared. We'll be posting it on our website, and hand it over to Lynette to get us started. Thanks so much.
Great. Thanks, Jocelyn. Good morning, everybody. Welcome. We are going to be talking about Hedis Measures for Collaborative Care today, and focusing on really linking and intertwining behavioral health and physical health measures to provide a person-centered care approach. Before we dive in, I'll introduce myself a little bit more and also my co-presenter. So my name is Lynette Thielen. I am a senior consultant at CCSI, and I work in the strategic analytics and quality improvement segment of the consulting team, as does Amy. And Amy, I'll let you introduce yourself quickly too.
Thanks, Lynette. Amy Jackson, Senior Healthcare Consultant, also at CCSI in the same division with Lynette. We work closely together on many endeavors along with our colleagues throughout the organization, and we're happy to be here today.
Yeah, so we are going to just go ahead and dive in. So I'm going to just tell you a little bit about what we're going to cover today. And we do have a lot of information, but we've also got, we're trying to work in some interactive content too, so we'll ask you a poll question somewhere along the way. We'll give you an opportunity for some discussion and sharing as we've gone through some of this information. But the focus of our session today is really understanding the importance of integrating physical health measures into a behavioral health setting. We're going to talk specifically about some Hedis measures. We've got kind of a lot of content in that area for you to consider about some opportunities to include in your measurement practices. And then we're going to move kind of outside of those measures and talk about population health, social determinants of health, and community data, and how you can incorporate those aspects to build a more robust data and measurement approach. We've got some information about data sources, and we've got a couple of really nice success stories that we want to share with you. So, so some really great content, and let's go ahead and get started. So let's start by just talking about this concept of integrating physical health measures into a behavioral health setting. And I think that it's pretty easy to see how doing that starts to bolster the ability to approach the achievement of the triple aim. So we know that as individuals, we're one person, and so our behavioral health, our mental health, and our physical health it's all one thing, and it's intertwined. So approaching things this way really helps to approach the overall well-being of the individuals that you serve, and it starts to really come at things from a whole person care approach. And it's really easy to understand how this approach can support improving outcomes and improving the overall care experience. And many of the measures that we're going to talk about today are very much a preventative approach, and we know that a preventative approach can very much support reducing costs. This kind of approach is also really a great opportunity to help you build your value proposition. So it gives you the opportunity to differentiate your value by demonstrating your effectiveness using data and measurement. And the measures that we're going to talk about today really align to the kind of measures that are important in value-based payment arrangements in your discussions with managed care organizations. And some of the high-level categories include things like follow-up after hospitalization or coordination of care, measurements that deal with use of acute services, client satisfaction, and screening and monitoring measures. And we're going to go into a lot more detail about specific measures, but you can see how these are really important factors when we talk about value-based arrangements. And at the end of the day, we know that an individual's behavioral health and physical health you can't separate them, it's intertwined. And we've got some interesting data points here that really demonstrate that. And it's very clear that if somebody's diagnosed with a chronic illness, they're going to be, have a higher likelihood of a behavioral health illness. We've got some statistics about individuals with diabetes, individuals who suffered a heart attack or have cancer, and how that really drives higher outcomes of depression and other illnesses. And it goes in the other direction too. So we know that individuals that have a mental health diagnosis or a behavioral health diagnosis are much more likely to have a chronic illness or medical comorbidity. So these two aspects really work together for an individual's overall health. As we said before, we are going to talk a little bit in more detail about Hedis measures. And so why Hedis? I mean, Hedis is a standard measurement system that supports the overall evaluation of care, and it provides a common language. So the measures that we talk about in regards to Hedis are common measures that are used across all healthcare environments. They're used by managed care organizations, by behavioral health, by primary care. And as you enter into arrangements where you're collaborating with or in contracts with some of these types of organizations, you have a common measurement practice, a common language that you can speak to in regards to Hedis measures. And all of this has really been kind of talking about things from a collaborative care approach. And we know that a collaborative care approach can really have some positive outcomes. So things like increased treatment adherence, improved patient satisfaction, increased mental and physical health. And at the end of the day, that really leads to overall better quality of life. So there's some very compelling rational reasons to be thinking about things this way. And really the biggest reason of all is it improves the lives of the clients that you serve. So from here, I am going to turn it over to Amy, and she's going to talk in more detail about some of these Hedis measures.
Thanks, Lynette. So, okay, so we're going to move into an area where we take a look at some of those measures and their categories and think about them in terms of how you are incorporating those into your daily practice with your patients. So if we could just look at the next slide. There we go. Thank you. You can take a look at this slide here to see that there begins to be an organization of these measures under different headers. So if you're thinking of measures in terms of women's health care, you'll see breast cancer screening, cervical cancer screening, chlamydia screening, osteoporosis management, prenatal and postpartum care. So if you consider the measure in that grouping, then you may begin to consider your patient population and how can you start to affect change according to population or groups of patients, and become mindful of what your patients might be in need of in a medical sense. So the idea being that patients that are engaged in behavioral health care are often seen much more frequently than by their primary care provider, who they may see once a year, or in many cases, not at all. And in fact, seeing your primary care provider at least once a year is a measured service. So those are the kinds of conversations that you can start to have with your patients You can familiarize the organization, so from administration, leadership, and at the clinical level. That opens the pathway to begin to encourage your patient population to seek those services, receive services that they might be in need of. You can incorporate these types of services into plan of care. So if you are starting to have those conversations, if you are beginning to collect data at the front with patient surveys, then you maybe can get a better sense of your patient population and what issues they're facing in a medical sense. You can help to coordinate the care, begin to practice giving referrals and doing follow-up to ensure, did the patient attend that referral session? Were they satisfied? Do you know your referring partners, and familiarizing yourself with the community at large? And you can support this work by collecting data that may already be at your fingertips. If you want to move on to the next slide, Lynette. So who is looking at these measures? We are talking about the NCQA Hedis measures, which are used by New York State in its quality assurance reporting requirement system, QAR. CMS also is using these measures, and the health plans themselves that are insuring the members are using these measures to assess how their panels of physician networks are doing. And the primary care providers and other providers in those physician networks are also looking at these measures. New York and CMS will evaluate plans by their success in achieving high percentages of their members receiving care in these measures specifically. The health plans are monitoring how their provider network is progressing throughout the measurement year. And the providers themselves are looking at these measures to understand how effective their care is. When plans perform well, they receive star ratings. So that will attract consumers and purchasers of health insurance. And by purchasers, we might mean Medicaid, CMS, Medicare Advantage, and also commercial insurance plans. So the plans will also benefit possibly from incentives if they are performing well as a plan, which means that their network is performing well in managing their patients' care. They will receive financial incentives, which can be passed on to the provider network. And more frequently, we're beginning to see that those financial incentives are actually being passed on beyond the scope of primary care, but right into the behavioral health settings. So again, some more measures to think about. Under utilization, we have acute hospitalization utilization, adult access to preventative ambulatory health services. So that's part of that annual primary care visit. Emergency department utilization, initial engagement of alcohol and other drug abuse or subdependence treatment. And then behavioral health has its own category: adherence to antipsychotic medications for individuals with schizophrenia, antidepressant medication management, diabetes screening for people with schizophrenia or bipolar disorder. The list goes on. So again, the idea is to become familiar with the measures that exist and understand how it can impact both administratively on a financial point of view, but also the patient's overall care. If we could just move on. And then the final slide of measures that we have called out here, you can see transitions of care, pediatrics, and preventive care sections. So beyond the incentives, revenue is greatly impacted by the attention and success in Hedis measures. The evidence tells us that focus on these health matters does improve the overall health of the individual and the population. And it's part of best practices. Payments are affected, patient health is effective. And so it's a good value proposition for your individual organization with a return on that investment. And I'll hand this back over to Lynette.
Okay, great. Thank you, Amy. I'm just going to peek at the chat for a moment. I don't see any questions. All right, great. We will keep moving on. So thanks, Amy, for talking about the Hedis measures and sharing, as you can see, there's a wealth of measures to take a look at and to consider. And we're going to take a moment now and kind of step back and think about some aspects beyond the measures and around the measures. So we know that there's a lot of facets to the health of an individual, and that things like the environment that they live, work, and play in, it impacts their health. The populations that people are part of are going to help us get a view into their health and potential maybe health issues that we want to address. And people are also impacted about how their care is coordinated across different providers. So if we start to go beyond the measure, we can look at practices that can really build an even bigger picture, a better picture that helps us drive towards improving outcomes. So we're going to start with population health and taking a look at that. And so population health looks at basically the health status based on a group of people. And in order to identify individual populations, you're going to have to disaggregate the data. And I've got a listing of a few different types of vulnerable populations that are basically, less able to resist or recover from things like illness, trauma, and disaster. And so as we start to look at something like some of these Hedis measures that we talked about, we also want to start to bring a population health lens to understand if individuals are part of vulnerable populations. And we have a few examples. And as you look at the different populations, you can understand the kind of data that you might need in order to identify these populations. So if you want to understand if you're dealing with elderly, obviously you have to collect their age. If you want to understand if you are interacting with a homeless population, you've got to collect their housing status. So you really need to start to look at your data practices to see if you can identify the populations that the people that you serve are part of. And why is this important? I'm going to have a really, really simple and straightforward look at why it's important to look at populations. So this is information about diabetes diagnosis in the United States. And we can see that if we just look at the overall number, that 10.2% of the population has been diagnosed with diabetes. So that tells us something. But when we start to disaggregate the data and look at it from different factors, we see a very different story. So the age one has maybe the most pronounced difference. When we disaggregate the data by age, we can see that the 65 plus population group is over twice as likely to have a diagnosis of diabetes. And if you serve a senior population, then this is going to start to, you start to put the pieces together. That's going to be an important factor. So are you tracking the population that you serve in terms of their adherence to getting diabetes screening and monitoring? And again, we have it disaggregated by race. You can see that the Black non-Hispanic population has a higher instance of diagnosed diabetes. So you can start to look at the populations that you serve and see where there might be some segments that look different than if you just look at the overall picture. What that can do for you is really help you target how you approach improving outcomes. You can then target to specific populations and tailor your approach based on the needs of that population. Another aspect that's really important to look at is the community. So people live within the context of their community, and understanding the characteristics and the health of the community is just as important as understanding the healthiness of the individual that's sitting right in front of you. And looking at the unique challenges in the community that you serve can help you align your measurement focus. So if you're in a community that has a high rate of obesity, or a high rate of diabetes, or maybe there's a high rate of children that have had positive lead screening results. You start to get more information about things that may be impacting that individual that is sitting in front of you. And it can really help you focus in on maybe what measures you may want to focus on. We saw a lot of measures, there were a lot of lists, so you've got to hone in and focus, and the community data can really help you do that. So that's another factor to consider.
Lynette, can you remind me, what are the questions on that, the diabetes graph we were just showing? I cannot recall off the top of my head. The question is that, does that include both type 1 and 2? It is accrued, it's from the CDC, and it is a crude overall chart. So I believe the answer is yes. We can always confirm that because it's 18 and over. So it should be a mixture of the type 1 and type 2. I don't know that the CDC made that distinction.
Yeah, and I don't know that off the top of my head either, but we have included the link to the data source. So that is something that you can easily look up based on the link, but I do believe it is both type 1 and type 2, but I'm not 100% sure.
Thanks.
Yeah. Okay, and so we've talked a little bit about population health and the community, and then there's also social determinants of health. And I know we're all pretty familiar with this, but we understand that the conditions that an individual lives in, the environment that they are born into, that they live in, that they work in, that they play in, that all has a very high impact on their quality of life. So, providing them resources that can enhance their quality of life can have significant influence on their health outcomes. So again, understanding these aspects of the individuals that you serve really helps in understanding how to drive to improved outcomes, because you've got to move to understanding the whole picture in order to really start to improve the outcomes for the individuals that you serve. Okay, so we are going to ask Jocelyn to pop in and help us with a poll question. All right, great. It looks like it is up. So we want to understand the data that your organizations currently collect. So we've got kind of just a general poll, and you should be able to choose multiple selections. So go ahead and take a moment to answer that question, and then we'll bring up the results. Jocelyn, I'm hoping you can see if people we're getting a lot of answers, or if the responses are slowing down. So whenever we get to that point, we can.
Yep. Yep, it looks like we've had about half of our folks take it. So I'm just going to give maybe another 10 seconds.
Fine, that's fine.
I'm not sure if you saw that, Lynette. One of the questions that popped up was what does SDOH stand for, which is a great because
yes, thank you.
All these acronyms.
Yep. Yeah. So that is social determinants of health, and one thing I actually want to mention is, so we had a couple webinars that were pre-recorded webinars that you could watch before you came to this. And if you haven't had a chance to, you can go back and watch those. And I spent a little bit more time going into details on that, but SDOH stands for social determinants of health. So can you all see the poll results? Okay, I'm never sure if I can see the same thing that you all can see, but what's great is we can see that there's a lot of our responders are collecting a lot of these data elements. So that is really great. Age is the most prevalent. A lot are capturing race and ethnicity. language. I'm really happy to see that expanded gender selections are included in there. And we can see that, you know, some of the, maybe the newer things that are not as common are the social determinants of health assessment. And again, apologies for not spelling that out. There are some standardized assessments that get at things like, you know, the living conditions, employment status, homeless or home status, things like that. So that's a lot of data incorporated into one place. And then community demographics and the health of your community. So those are definitely areas of opportunity. And I think the community data is something that we're talking about more and more, and it's maybe it's a newer concept to some of you, and obviously some of you are collecting it, but something to think about if you're not already. Okay, so I'm going to close this. So thanks so much for sharing. I appreciate that. And I'm going to turn it back over to Amy to talk about data sources.
Okay, so next couple of slides, we'll take a look at some data sources that can help inform your practice if you are ready and willing to begin considering physical health in conjunction with behavioral health services. So really just even what the poll was really touching on, your own EMR or EHR. So a lot of information that can help guide you or steer you that you can pull directly out of your own system, including your client demographics, what services are being scheduled, what services are being the predominant services that are being delivered, how engaged are your patients, do you have no-shows? Those are all different kinds of things that can help begin to shape how you're going to move forward in considering your steps in incorporating healthcare into your medical healthcare into your behavioral health. So understanding no-shows can lead to another set of questions. Are there barriers to transportation? Are people physically unwell in a way that's preventing them from coming to their behavioral health visits? Patient surveys. So one of the ways that we can collect in particular information about those social determinants of health is to begin collecting expanded patient surveys when patients begin care. So you can also always resurvey. So you can start to see a progression of either upward or downward in patient satisfaction, things like access to food and other resources, if there's exposure to violence in the household or in the neighborhood or area that a person lives, access to housing, what is the primary care provider that a patient has, and what is their name and maybe their other contact information. And if that's blank, that can tell you something else. Perhaps the person doesn't know who their primary care is or primary care provider is, or doesn't have one engaged yet. So that kind of information can be garnered outside of the EMR, but in an actual patient survey. Psyches is another great resource for data. This is the Medicaid billing claims and encounter data. Patients are identified and flagged for services that they might be in need of. So that's a great resource to understand who's receiving care, where all are they receiving care, and what services, where might there be gaps in the care that they need. Next slide. And considering some additional data sources, we have RIOS. So RIOS is the local hub where the regional health information is gathered and stored electronically. Access and exchange of health information with those that participate in the RIOS system regionally. It can alert you to people that are admitted and or discharged from the hospital, for example. In many cases, it's public information once you are, kind of enrolled in that RIO system, in your regional RIO system. And so there may or may not be fees according to the level of alerts and reporting that you're requesting, but it is a fantastic resource that should be considered if it's not being used in your practice already. Multiple public sources. There's a variety of public health data that's very valid, very reliable, and you can find data at the local, county, state, and national level. And this can help you understand how your region is doing, how your state is doing, and then also how are you doing in comparison to those measurements. And then the health plans themselves. Reach out to your health plans, contact your provider relations. Often health plans issue monthly or quarterly reports. They may be able to exchange your patient roster of everyone that they have in their records that are assigned to or have been seen at your practice. So those are conversations that you might want to consider beginning if you're not already engaged with your health plan. And I don't have a good concluding statement to pass this along, but those are some data sources, again, to help shape your ideas. I think Lynette touched on it previously, and I didn't say it, and I apologize. We're not suggesting that you're going to look at all of those measures that we had a few slides back, but we're talking about starting to get ready to integrate. So you can use that data, you can start to focus in and hone in on a few measures or one or two, with small actionable steps. If you can understand the makeup of your population, the population of the community that you serve, you can select measures of focus that are meaningful to you and your patients. Start small, and then over time, you can grow your competency and capacity to manage this at a in greater detail and length with your patients, and just increase that efficacy over time. And now I will pass it to Lynette.
Yeah, and Amy, that actually did turn out to be a pretty good segue, because really what we want to do is move into a breakout discussion where you can start to talk about the opportunities that maybe you're thinking of based on some of the information that's been shared today. And before we dive into the breakout discussion, I just wanted to share a comment that came in from our last poll, because I think it actually might be a conversation starter for this individual or for some other groups. So Karen chatted in that they don't do a formal social determinants of health assessment, but they cover it in their intake conversations. And I think that was a great thing to share, Karen. I appreciate it. One thing maybe to think about and even discuss in the groups that we're going to go to in a minute is the value of covering it in a conversation with the individual and capturing it as structured data that you can then act on and incorporate into some of these measures. Those might be two different things. So that might be something to think about.
Just as a side note, I'll just add, we do have a link to some assessment resources. So
yep.
At the end of
Thanks, Amy. Yeah, we've got a few resources at the end that you'll be able to access when you can get to the slides. So for our breakout discussion, and Jocelyn, maybe you can just kind of get started. I think with the number of people that we have, maybe 15 groups, we can get groups of like 5 or 6 people, that would be great. And we're gonna give you, I would say, a good 15 minutes or so. Amy, does that sound good? 15 minutes?
Yeah, I'd say 10 or 15 for discussion.
And really what we want you to do at this point is just start to talk about some of the opportunities. So we shared some information, you've shared some information with us about what you are collecting. I think this is a great time to pause and discuss with each other what you're seeing as opportunities to think about from here. And that could be opportunities to integrate some additional Hedis measures that you don't currently have. It could be some opportunities to expand some of your data collection practices to start to get at some of those other data components like the social determinants of health, the community data, the population health characteristics. So that's really what we want you to focus on. So Jocelyn, I will ask you to let people move into the breakout rooms from here, and we'll give you 15 minutes to discuss with each other these ideas.
Sorry, Lynette, we can't actually do breakout rooms in the webinar function of Zoom.
Oh, okay.
For some reason I thought we had talked about this, and apparently no, I apologize.
Okay. We will adjust. So instead of moving into breakout discussions, Jocelyn, are people able to unmute themselves if they want to share some thoughts?
Yep, I can give everybody that capability if you just give me 1 second.
Yeah. So while Jocelyn's working on that, we certainly have the chat function. And maybe what we can do is ask you to share some of your ideas with us. You can either chat them in to us, to the whole group, or you can bring yourself off of mute. And you can either share some things you're thinking about doing from here, or if you've got some things that you are currently doing that you think would be really great to share with the others on this call, we welcome that also. So Jocelyn, let us know if people are able to unmute themselves at this point.
And it could be easier actually if folks want to raise their hand, and I can also just unmute you directly.
Okay, somebody is saying that we can do breakout groups, but unsure how to do them. Yeah, I don't think in this particular format we have the functionality to do that.
Yeah, it's the difference between meetings and webinars.
Yeah.
Okay, someone unmuted me. My name is Gianna. I work for Bureau American Action League, and I'm a HARP and Health Home Plus Care Manager. And something that we really focus on, and I mean, granted, I've never seen other agencies, you know, data and stuff, but we focus especially on like the social and community social determinant of health. So we make it a point, not just in like crisis plans and stuff, but to really identify people's supports, whether they're paid, whether they're natural. And I mean, that's a huge part of, you know, being a care manager, making sure people have that support. So I think that works really well for us.
When did you begin doing that practice? Do you have a sense? Has it been, 12 months or 3 years? I'm just curious.
Personally, I've only been here since February. Previously, I worked in HCBS services, and I had less like access to data then. So, I mean, I used it. I mean, my background's in public health, my undergrad. But yeah, I like how we collect a lot of that here at Bureau, the social.
Great. And I was curious in terms of, do you have a sort of a standardized assessment that you implement with all the individuals that you serve in terms of all those social determinants of health factors, or is it gathering that information from just sort of different aspects and not necessarily a structured questionnaire? I'm curious about that aspect.
Yeah, so I forgot the person's name. Someone replied earlier and said it's kind of just implemented into the comprehensive assessment. And I do mostly like eligibility assessments with HARP people. And yeah, it's not like, oh, section for social determinants of health. It's definitely more part of like the conversation in there for sure.
Great, thanks. Carol we're getting a few people chatting in. So Carol mentioned that they're beginning to look at measures level and how the behavioral health network interacts with CBOs to address social determinants of health needs, and that can impact engagement and treatment. And Carol, I think you brought up a really good point about the network, a network interacting. And one of the things when you start to work across a network, just standardizing how that kind of data gathering happens can be so incredibly useful. And I don't know if it is standardized across the network for you at this point, but and if you're able to let us know, that would be great. But I think you've brought up a really good point about thinking about this from a network perspective. So thanks for sharing that. Another aspect, maybe if we can get anybody to be willing to come off mute or type in the chat. I did see that there were some individuals that mentioned that they are working with community data, and we saw that wasn't the most prevalent in our list. So I would love to hear from some of those organizations if anybody's willing to jump in and share some of their experience with that. And while we're waiting for that, Carol, thanks for jumping back in and noting that they're using the BHCC view with psyches to help look at data from the network perspective. And for anyone who is not familiar with that, A network has the ability to have basically a network token with psyches. So you can kind of grab the data for the whole network at one time through that aspect. So that's a great piece of information. So thanks for sharing, Carol.
So Lynette, do you know if that token is applicable to IPAs in addition to?
Yeah. Yeah, so that's a good point. IPA organizations and BHCCs have ability to get that network token.
Yeah, so Boris just wrote in, and this is kind of what I was thinking about in relationship to those questionnaires. So, asking if somebody has a PCP. And then really the next question is, so if you're collecting that data, then what is it that you're doing with it? So are you validating that it is the right PCP, that they're familiar with where that PCP is located, how to access, how to reach the PCP, their primary care provider, in what instances might they want to be reaching out to their primary care? So if you're collecting the information regarding social determinants of health, and then also sharing that at the clinical level. So that clinician now has that opportunity to start building a care plan that incorporates some of that information that's being extracted off of the questionnaire or assessment. And really kind of touching back on something that Lynette said is maybe even thinking about the value of is it being discussed, or is it being collected and then moved through the organization, quantified, so on and so forth. So I don't know if you want to talk a little bit more about that idea, Lynette.
Yeah, no, I think that's a really great point. There's sort of like different layers along the continuum, and I think that it's a really good idea to think about where you're at and where you might want to head. So there's having discussions with the client and gathering some information in an anecdotal way or in a way that's captured in notes, and it's being captured, and that's great. But then moving up to the next level, being able to capture the data in a way that's structured and can be reported on and extracted from the system is sort of the next level to think about. And then really making use of that data, sharing it with the staff, with the organization, with the clinicians. So those are kind of, if you think about it from a continuum perspective, just working your way up the continuum is really important to think about. I see we've got a few other things coming in through chat. So Catherine has mentioned that they have Article 31 clinics and health home care management for children, youth, and adults. So they use a standardized social determinants of health assessment tool, and that's completed at intake when the individual or family circumstances change, and updated at least one time per year. That is really a great point. And then the results are translated into diagnostic codes. So it sounds like that concept of taking that data and making sure that it's in your system in a structured way is really part of what you do. They're a member of the Healthy Alliance IPA, which is a social determinant of health network, and then you refer throughout your platform for resolution of those factors. Oh, and you utilize the Unitas platform. Thank you for clarifying that. That's great. That's awesome. Thank you so much for sharing that. And I think that was a really great example of what we were just talking about. Amy, do you want to talk to what Karen just typed in? We've got a few other things typed in. We'll try to get to all of them. So that's good.
Sure. So Karen is saying that she's working at an independent living center representing peer programs, which is a unique set of services that have a lot of unique billing requirements. And so also the population that you're treating and the services that you're providing are very much affected by the SDOH, the social determinants of health. You're beginning a peer RX program at 2 emergency room departments. That's wonderful. We just began within the last 2 weeks as certified peers. We work daily within the social determinants of health workflow, work with the whole person. Absolutely. Advocates are certified within mental health and substance abuse field. I love it. You're a peer-run ILC community agency trying to work as a team with the medical world. Trying hard. So we do not, so you're trying hard to be part of the team that supports an individual. Do not divide a person. They are whole, which
Yeah, I love that comment, Karen.
I feel like Karen, you should have been sitting here. That's great. And I don't know if you are comfortable, if you want to go off mic and talk about some of the barriers that you're encountering, or in some ways that you may have overcome them, some of those innovations that, because it's non-traditional. We're so used to all those silos. This is your primary care, this is your specialty, medical services, here's your behavioral health. I'm just curious if you've encountered some challenges and found some successful ways to circumvent. But again, no obligation. I don't want to force anybody to speak if they're not comfortable doing so.
All right, well, thank you, Karen, for sharing, though. We think that was great information, and it sounds like really the integration of the medical and behavioral health is a key factor. I think bringing up the point that you're working through challenges, and it's a culture. It's a culture for both organizations, and I think that's a really good point. Is that this kind of integration, especially when you are directly interacting with other organizations. You know, it's a new way of working, and Karen, you bring up a really great point, because you're saying we need to understand each other and respect. It's like doing a new dance. You've got like the best analogies, so thank you so much for all of your the way that you're providing the information to us. I really appreciate it. But I think it's a good point, because it's not you know, when we talk about it kind of in this context, it might sound a little bit cut and dried, and it's definitely not. So I think there's a lot of aspects that, you know, maybe it takes some time, it takes some understanding, it takes continuously working on things and improving how you interact with each other. So those are some really great points. Thanks everybody for the sharing that you've done with us. And Karen, you know, you just brought up another really important point, that there's a need for all of us to support an individual. And kind of going back to your original point of, we don't divide a person up when they come in to see us and say, oh, we're working on half of you today, or a quarter of you, or a piece of you. So you only need to bring in that part of you. So and you know, just reminding us that at the end of the day, that's really what we're all here for, is to support the human beings, the individuals that are out there that need support and need care in a way that really is most helpful to them. So that's really what's at the basis of this discussion. So
yeah, and that brings to mind too that idea that we're kind of enmeshed in the health system, and we're much more familiar that the patients that we're dealing with need assistance even in just navigating through their areas of care can really be overwhelming and daunting. So that's, you know, this incorporation of your medical health services into your behavioral health care opens again a new pathway to help really hold that patient's hand to a degree to get them to the services that they need outside of the scope of just their mental health, which circularly ends up affecting their mental health positively. So that came to my mind. Lynette, I don't know if there's value in sharing. We could share that link and show what some of those SDOH questionnaires look like. We can, you know, for doing screen sharing, as long as our breakout session.
Yeah, so why don't we actually have some success stories. So why don't we go through those, and then if we have some time to dive into some of the links that we have, we will try that. How's that sound?
That sounds great.
Okay, so, oh, go ahead, Amy.
I was gonna say, since we do have this extra time, I thought I would, if you want to stop sharing for a moment, I can share a link. So moving into success stories, Montefiore has developed a framework for integration of general health in behavioral health settings. What was intriguing is that it's this idea of this reverse integration. So commonly, and so much of the literature really is around embedding behavioral health into primary care. But from the perspective of behavioral health providers, you already exist, you have your brick and mortar, and that may not be practical. It may not be practical to also be providing care inside of a primary care office, although that is an option. It may not be practical to bring primary care into your setting. So then you need to become familiar with your external partners. So your external partners are those primary care offices that operate under their own tax ID and business separate from yourselves. And that's why I was particularly attracted to this Montefiore integration of general health and behavioral health settings, which they have coined as GHI, under reverse integration. That idea of, from the behavioral health point of view, working outward with your clients to make them connected. So I can go ahead and share this link, or this actually it's a PDF. So what I found so helpful in this document as we were doing research for this, and you can see it's a 42-page document, not suggesting that you need to read it all, although it's a great read. But if you move down towards their appendixes, you can begin to see that
Are you sharing, Amy? I'm not seeing anything on the screen.
I appreciate that. I don't think I did fully share that, did I? I have it open. There we go. Are you seeing it now?
It's coming up.
Okay.
There we go. Yep.
Thanks. So if you,
I can only see a portion of it, just so you know.
yep.
There we go. That's the whole thing.
Yes. So I'm just going to shrink it down just a little bit so I can navigate it. So I'll bring you back to the cover page, Advancing Integration of General Health and Behavioral Health Settings. It's a framework, but I especially liked the appendixes for the purposes of anyone who's interested in exploring this more fully. You can begin to see that they have, and bear with me as I page forward, kind of a guidance. So readiness self-assessment tool for general health integration. So here you can begin to consider your own readiness. And then using this as guidance. And then general health integration under the readiness, they may have suggested areas. So individuals screened must receive follow-up by a trained behavioral health provider or PCP, depending on the needs, so on and so forth. And they've separated it into domains. So domain 1, screening, referral to care and follow-up. Domain 2, evidence-based care for common general medical conditions. Again, familiarizing yourselves with what is predominant to be in its consideration for general medical conditions. So I think we touched on these to a degree. Diabetes certainly comes up, health, heart care, so on and so forth. And you can assess your organization through these domains, and then again, use this as part of your planning, your framework experience. So section 3, provide feedback on your integration team's experience using the framework during the course of completing that survey. And again, just a tool for you guys that might be useful in this endeavor as you move forward. I think our participant Karen said they'd just begun within the last 2 weeks. Some are in the contemplation stage, some may be beginning this work, and some in this audience might be fully immersed in it. But I did want to share that. I thought it was a great resource to help frame this for folks.
And Amy, a couple people typed in while you were sharing, definitely are interested in the link. And I don't think this is in our resources links yet, but we'll make sure we add this on to our resource links that we've got already in the slides so that you can access this. So thank you.
You got it. And that's really, we were moving into that section of success stories. This was one of the highlights here, the Montefiore care management system. And really it's designed for a variety of providers with a spectrum of resources. So as we know, some practices have a lot of resources available to them by the nature of their size and scale and scope. And then others are acting really independently and, need to start thinking about these things in a different kind of a way. As I said, it's not necessarily practical to have a primary care provider on site. It's not practical to be on site at a PCP office, but you can start making those linkages. And then the other success story I wanted to mention is As One IPA. So that is an IPA in the New York City area that has focused specifically on the family unit in its consideration and care of their patients. So they are taking, I have some notes, they are taking that focus on family systems and the care needs of all in a household, which is also supported by the Hedis metrics. And so they are not only taking that approach, but then, measuring how it is that their work is affecting their patient population. And what this does is it creates a value proposition for that IPA, which then they can begin to leverage in their contracting with the plans. So now they have that value that they can demonstrate that they can bring with them in their negotiation and contracting in their value-based payment agreements. And they've already begun the work in the measures so that when they're engaged in a value-based payment agreement, those measures that are attached to the VBP or the value reimbursement method that they're contracted with, those measures are not coming out of nowhere. This is not a new introduction to them because they're already immersed in those measures. And they're taking that, again, that family approach. So they are familiarizing themselves with the care, the medical care needs of maybe the children, although the patient in the behavioral health setting may be the adult. But if they're understanding that there's young children in the household, then they're having those conversations about pediatric immunizations and pediatric well visits. If there are older people in the household, then they're having those conversations about medication management and post-discharge, after hospitalization visits. And again, they've discovered their value as a network of providers. And let's take a look.
And we had somebody look up the link while you were talking. So I did share that in the chat, but we will again include it in the slides. So I do have a couple other success stories to add. So Amy, if you want to let me display, I will go over those, and then we will, we've got a couple other slides, and we'll also leave some time for questions and answers. Now let me make sure. Okay, great. Can you see my screen again?
Yes, we can.
Okay, great. All right. So just a few more examples of organizations that have started integrating some of these physical health measures into their practices in different ways. And I think there's a lot of different ways for this to work. So I think it's nice to see a few, some different aspects, because we're all different kinds of organizations, and there's going to be different ways that you can incorporate these things to provide the best results for your organization. So this was a collaborative care initiative to improve the overall health of patients with mental health disorders. And this was in a Veterans Affairs organization. And what they really wanted to do was determine whether a collaborative care model would have an impact on the physical health of the patients that they serve with mental health disorders. And they were doing this over a 12-month period. So this was a controlled study of the collaborative care model. And so they had a control group that did not receive the collaborative care model, and then they had the group that did receive it. So the collaborative care model provided the clients with some 5 weekly group self-management sessions where they covered education on things like risk factors, goal setting, coping strategies. They implemented ongoing care management contact. So there was a contact with those individuals to reinforce the learnings that they had, to help them track their activity, their dietary goals, and also create a linkage to communication to their providers as was needed. And the providers that they linked them to received mental health guidance on how to manage risks in cardiovascular disease risk in patients with chronic mental disorders. So there was a lot of different aspects that were used in this collaborative care model. And over that time period, it resulted in patients having a demonstrated increase in health-related quality of life at follow-up in comparison to the control group. And they had statistically significant results in terms of a decrease in body mass index, waist circumference, and physical activity, an increase in physical activity, reduction in LDL cholesterol levels, and just improvement in overall health-related quality of life scores. So this is a really nice example of how several different strategies were intertwined to improve the overall health of the individuals served, and was a really good study in terms of being able to compare that collaborative care model to clients that did not receive that care and see that there were significant results out of that. And then the second example that I have is dealing with children and adolescents. And this was children and adolescents in a mental health services setting that were receiving ADHD medication. And this particular initiative was really around improving their physical health monitoring. So the goal of this was to measure the increase in monitoring the physical health conditions, which really could provide the basis for then doing some improvement activities. So this aimed to improve compliance with monitoring things like blood pressure, height, and weight over a 12-month period. And they used PDSA, Plan, Do, Study, Act improvement cycles to promote the practice among clinicians. And they also used a web-based app to help record health metrics. So they were able to measure that there was improvement in monitoring over the 12-month period. And overall, the compliance with the measures, those three measures, went from 24% being implemented to 75% at the 12-month follow-up. So definitely, this was focused on not so much the content of the measures, just actually getting that in place, which is the foundation. So now that they have 75% compliance with that, they can work to improve it, but they're also going to then start to get some data about those health measures in those children and adolescents, and that can then become something to do more improvement cycles on. So 2 very different examples, along with the information that Amy shared. So I think hopefully that gives you a wide variety of kind of a view of how these things are being implemented. So we'll just kind of start to wrap things up. We've talked about a lot today. Thank you so much, everybody, for sharing your thoughts and ideas as we've gone through this, and asking any questions as we've gone through. And we'll have the chance to wrap up with any more questions. But really, the focus of this is talking about those Hedis measures and how those can be used to cross over behavioral health and physical health, with the objective of improving the overall health of the individuals that you serve. The benefits of this are, of course, first and foremost to the individuals, but it also improves outcomes overall and supports the objectives of the triple aim. And really helps you articulate the value and the differentiation that you bring. We know that in order to get to some of the data that we need. There's the measures themselves, which are extremely important, but there's other factors that can get you to a deeper understanding of what's driving the overall results and can give you pathways to start to improve your outcomes. And that is, you know, through that population health, through the social determinants of health, through the community data, adding that onto the measure for really a bolstered effect. And Amy, anything else you want to add at this point before we kind of move on to resources and things?
Well, and I just think that we would state again, the idea is to start small with a focused intention, stay committed, develop momentum as you go along, and that, you know, as you can increase your understanding of how it's working operationally, develop operations around what it is that you're doing, and then you can build the capacity to increase it. I think even in your last example, Lynette, with that 12-month look back, it gives that momentum to the work that's being done and opens space for more work to be added to the work that's already been, you know, accomplished.
Yeah. I just was peeking into the chat. I know that there were some additional links that were shared. David had to hop off, but he did share a white paper. So I think everybody has access to those. And again, we can look at adding things to our resource slide. I'm just going to pop over to that real quick. We may come back to this. I want to make sure we leave time for questions and answers. And there's just one last thing that that MCTAC wants to communicate too. But we've got links to a lot of resources. We're going to add a few, so we may end up with 2 slides of resources. There's resources, you know, for NCQA, resources. There's a link to some standardized social determinants of health assessments. I mentioned before that we had some pre-recorded webinars that were intended as some foundational knowledge for this. If you didn't have a chance to see those, we've got the links for those here. Any other ones, Amy, that you want to touch on?
I think now this is covered, and I did know that the slides were kind of done before we got that link for that last document that I did share, but we will add that before we send this out to everybody.
Yeah, yep.
And then I would just add if MCTAC has anything that they wanted to add at the end of this, if any information.
So I think
we're good. Thank you.
Okay.
Great, thanks, Boris. Okay, so I think people have been kind of asking questions along the way, but let's open it up one last time and see if there's any additional questions or thoughts. I think the sharing of information is just as, if not more valuable than the questions that you ask. So let us know if there's anything else that we haven't covered here today that we can help you with.
Yeah, and we're welcome, you know, we would welcome any thoughts or comments about what information you would like to see in relationship to Hedis measures and incorporating and integrating medical health and behavioral health. If there's any thoughts out there, feel free to share.
Yep, and folks, you're welcome to use your raise the hand function, and I can unmute you. You'll see it as a choice at the bottom of your webinar screen.
I think people are, it seems to me that most people are satisfied with their questions at this point.
Yeah, I think so. So Jocelyn, are you going to cover the slide?
Yeah, you can move on to the next slide so we can share with folks. I did mention it briefly in the beginning that it is the same link, but you will notice an updated website. So it is still that ctechny.org, but the picture that you see here is actually the homepage when you go to that website. A little bit more user-friendly. Login features, new search functionality. In fact, when you click for looking for a recent training, I tested this today, you know, it brings up the search right away. So instead of having to scroll all the way to the bottom of your screen, you can type in even Hedis, and then you click the search button and you will see the 2 posted pre-recorded webinars for this series. They pop right up. You can click on those links. So it's definitely really great. Again, you'll see all of these updated features listed here on the slide, series and playlists, special initiatives. If you have any questions, these two emails, ctech.info@nyu.edu as well as mictech.info@nyu.edu. You can always email them, questions, comments, concerns. Maybe you just need a little bit of a directional pointing to something in particular. We're always happy to help, so feel free to use that. And yeah, we're excited to get some feedback on what you think about the new site. Thank you so much today to Lynette and Amy. I don't see any other questions or comments. Thank you to our MCTech partners for allowing us to do this. And again, if you also have any questions about this series, feel free to use that mictech.info@nyu.edu mailbox. And we will be posting this on the website within the next 24 to 48 hours. So thank you so much for joining us and take care.
Great. Thanks, everybody.
Bye, everyone.